Friends, I'm back. We are here to talk about angina and the drugs to treat it. So what exactly is angina, do you say? Well, angina is essentially a supply-demand problem where there is not enough oxygen being delivered to the myocardium. So angina pectoris is a kind of a constellation of symptoms, or it's a word, I guess, to describe the constellation of symptoms that result from inefficient or ineffective oxygen delivery to the heart wall, the muscle cells, cardiac muscle cells. So most of the time that's due to inefficient blood delivery to the cardiac muscle cells via the coronary arteries. Since angina is really just a group of symptoms, the symptoms that are sometimes present, not always, I should say, not always present, but the symptoms that are sometimes present are most classically sudden pain, intense sudden pain, sometimes referred to as crushing chest pain or substernal, so just underneath your sternum, substernal chest pain. Sometimes the pain will actually radiate to the left shoulder. This is a little bit more common in men, or down the left arm, so to the left shoulder and then down the left arm. It might also go to the back, kind of the thoracic region of the back, maybe the shoulder, maybe the middle thoracic region, or it can move up towards the jaw. So those are the classic angina symptoms. It can also present as epigastric pain, kind of like sort of, not very specific. Epigastric means kind of above the stomach, so like kind of right beneath your xiphoid process. And oftentimes in that presentation, there's kind of like sort of a sense of doom, right? Impending doom or panic or anxiety or, foreboding, that kind of thing. Other symptoms that may be visible are people tend to be pale. They might be short of breath. They might their skin might take on a bluish hue. That's what cyanosis is. They may be sweating. That's what diaphoresis is. Their heart rate probably is increasing, and their blood pressure can increase. So those are all just options, right? And keeping in mind that not every person experiences all or any of them. So it really, I guess what we want to think about, let's look at some pictures. When we think about angina and symptoms, really what that's telling us is it's telling us that there's something going on with the oxygen delivery, the blood delivery to the myocardium. And the disease, which is, again, that's something I want to kind of use loosely, but what can cause this to happen is narrowing, plaquing and narrowing, and ultimately occlusions in the coronary vessels, which is what you see on that picture there. So these are our coronary vessels, right? So we think of the heart being a pump that pumps blood to the rest of the body, but of course, in order for that pump, which is hugely metabolic, really active, pumping 60 to 100 times every minute, it needs that the muscle itself needs to have a steady supply of oxygen, and the way that we get oxygen to our tissues, of course, is via our blood. So when there's any kind of narrowing or blockage in our coronary arteries, that's going to inhibit blood flow and ultimately affect perfusion downstream of the area of narrowing. Or in some cases, the coronary vessels will spasm, and the downstream tissue downstream of the spasm will be affected. So here's a drawing of some coronary arteries. This is looking at the right and the left coronary arteries here coming off of the aorta, wrapping around. This is a super cool picture. This is all the coronary vessels shown with all the rest of the heart tissue gone. So you can see how incredibly vascular the heart is and how many places we can actually cut off some blood flow. Obviously, the larger the vessel, the more significant the situation. Interestingly, people don't generally present with symptoms, even if they do get symptoms, they don't generally get them until they're at least 70% occluded in a major vessel. So that's kind of a long ways away from the beginning of the problem, right? So the absence of symptoms don't necessarily tell us that there's no coronary issues. Okay. So, sorry, my phone is beeping. So let's see here. That's another picture of a coronary vessel, of coronary vessels which are being visualized with some contrast media in there. That's perfectly normal. Everything looks really good. When we look at coronary vessels, where we kind of want to focus our attention for potential problems are places where the vessel bends or splits. So like right here, that's a bend where it splits, like right in this area, upstream, generally just upstream of that. Another one right here, these are called bifurcations. Here's another bend over here. So those are things that we kind of think about. Here's a picture of an actual problem. So where the arrow is pointing is actually right here, and when it's blown up. So this vessel you can see is full of contrast media, and then the vessel is narrowed at here. So there's got to be some plaquing down in here, and you're not able to get blood through. Excuse me. So that potentially could precipitate some symptoms. This is another picture. You can see it over here. This is what the inside of the vessel looks like. This weight, all this weight stuff, and all of this stuff, this is all plaque, right? It's really bad. And this black spot right there, that's the patent part of the vessel. That's the only place that the blood can actually get through. So this can be a real serious problem. That's another really nasty looking vessel. I mean, it looks bad on so many levels, right? Remember, this is this inside of a blood vessel, which is supposed to be smooth, open, so blood can flow in that laminar fashion, which is the kind of blood flow we like to see. What would happen here is a lot of turbulent blood flow, which is more prone to clotting, which then would, if a clot did form in that vessel, that would completely occlude the vessel, because the vessel is just going to continue to get smaller, and which would cut blood flow off, totally, which seems to be the most likely cause of a lot of our sudden cardiac events. All right, so let's get back to angina for a minute. So, like I said, this is a supply-demand issue, right? It's where we have a mismatch in oxygen supply versus demand. So generally, when we think about things that can cause this to happen, in terms of causes related to the oxygen supply, and what I'm talking specifically about here is the myocardium. So atherosclerosis, that's what I was just talking about, a coronary artery disease where we have narrowing of the vessels due to plaquing, clots, etc. Spasm of the vessels. There's different types of angina. There's what we call like typical and atypical angina. This would be the atypical kind, or sometimes they call it variant angina, and it's due to a sudden spasm of coronary arteries, and why that happens, it's a mystery. There's some evidence that it could be inflammatory, there could be cell signals, that kind of a thing. Sometimes this type of angina is called vasospastic, or historically has been called Prinzmetal's angina, which doesn't really help, but vasospastic makes a little bit more sense, telling us that that vessel is in spasm. When it's in spasm, it's clamping down, right? When the spasm releases, the flow would be returned. So for that reason, people with vasospastic angina, oftentimes the angina is elicited at weird times, like at rest, when they're not under stress or exertion. Most of the time with angina, we would expect when somebody exerts themselves, you would expect to see that precipitate an attack, right? Because the demand on the heart will go up and you're not able to increase supply. You're not able to get blood through those closed vessels. But in the case of variant angina or vasospastic angina, the vessel is not permanently closed, it's just in spasm. So that's something to think about. Another thing that can precipitate angina is anemia, right? Anemia is a decreased oxygen carrying capacity of the blood. So what has to happen if the blood is poorly oxygenated? One of the things that will happen is the work will go up. The heart will work harder to pump that poorly oxygenated blood around. There's some causes related to oxygen demand, and those are going to be things that are going to obviously increase the work of the heart. That would be hypertension, pulmonary hypertension, valve disease, other things could do it as well. Heart failure we could probably put on there. There's all sorts of things we could put on that list. So the angina is going to be precipitated by either a cause related to oxygen supply or related to oxygen demand. one thing I would like to mention with especially with atherosclerosis, because that is a chronic condition where we have, areas of increased narrowing of vessels, that will also increase resistance. And you can have atherosclerosis in the coronaries, which is what I kind of was alluding to, but you can always also have atherosclerosis in other vessels, which would increase total peripheral resistance, which would also cause an increase in demand. And then finally, attacks can be precipitated by exertion and stress and emotion and those kinds of things. And that's pretty typical in our typical type of angina, or what we would call stable angina. All right, so let's see how we would think about managing this. So when we're here to talk about drugs, and I will preface this by saying that the medications are sort of a Band-Aid in this arena. They are not curative. What they're going to do is either halt, which means stop, an acute angina attack, or decrease the frequency of attacks. So if someone's prone to angina, they may be put on a medication prophylactically to decrease the frequency of attacks. So one or the other. There's going to be some drugs that are going to be better at one than the other in terms of mechanism. So that's kind of what we want to talk about. So the main way that they're going to work, these anti-anginal medications, is by reducing, oxygen demand, myocardial oxygen demand. That's really what we're trying to think about here, right? Keeping in mind that angina is just a symptom of, in most cases, a larger problem. So to deal with the symptom, it's fairly downstream intervention here. What we're thinking about doing is anything that could immediately decrease demand. So things like that are going to slow the heart rate down, makes the heart work hard less, decreases work. Dilating veins, this is a big mechanism. Dilating veins, which may or may not be an obvious choice, but when we dilate veins, we decrease venous return to the heart, so the heart's receiving less blood, which means there's less blood in there, which means the heart has to pump less hard. That's kind of sounds not right, but so it decreases the work by reducing preload. Remember that term, preload? That's the blood coming, front loading the heart, if you will. We can also decrease the force of contraction, which would decrease work. Long term, maybe not a great idea, but in the short term, decreasing the force of contraction will definitely decrease work, hence decreasing oxygen demand by the myocardium. And finally, we can lower blood pressure. That would reduce afterload. Remember, afterload is the amount of tension the heart has to generate in order to eject the blood. So you generate less pressure to eject the blood, then that's not as hard. It's not as much work. So that would be reducing afterload. So that's kind of how you think about these things. I have a little picture here that shows us the three most common mechanisms of action by which drugs will affect angina, treat angina, keeping in mind again that this is a symptom management. In your book, the order of which we discuss them are, I believe, beta blockers, calcium channel blockers, and the organic nitrates. They're not listed in order of use. They're all used for kind of different things, but we've been talking about beta blockers a lot. We should be getting the hang of these guys by now. They're going to decrease heart rate, they're going to decrease myocardial contractility, which of course is going to reduce cardiac output and also decrease workload. Calcium channel blockers are going to kind of do a lot of things. We've talked about them a lot as well. Calcium channel blockers in this context are going to dilate arterial smooth muscle, reducing blood pressure and decreasing cardiac work. They also have a specific effect on the heart rate, reducing work, but most specifically, they're the only ones that really seem to have pretty decent efficacy. Well, not the only ones, but the only ones on this slide, I should say, that seem to have pretty decent efficacy in terms of dilating coronary arteries. The nitrates below, they do that, but that doesn't seem to be the way that they are most effective. They do that a little bit, but the calcium channel blockers are really good at doing that, and therefore they can be pretty effective. Then finally, the organic nitrates, which are probably the drug of choice for specifically acute angina attacks. Their big action is venous dilation, so decreasing preload, like we were just talking about. They do dilate the coronaries And when you dilate the coronaries, of course, you're bringing more blood, so you're increasing supply. But one thing we have to think about is if there's atherosclerosis and there's hardening of those vessels, dilating the coronaries is off the table. That's not an option, because once you put some spackle in there, if you will, you can't get those things to respond. So that's not the most effective. All right, so we'll come back to those. I want to talk about them in that order, I believe, starting with the beta blockers. So atenolol is a good example. I believe we used that atenolol as an example in the conversation about dysrhythmias as well. This is a beta-1 selective drug. Slows the heart rate, decreases contractility, both of which are going to decrease demand. That's really the deal with beta blockers. Beta blockers are not for acute use. Right, they're not going to stop an attack, but they are used prophylactically to minimize further attacks. So they're someone who's got chronic angina. These guys could be used to kind of prophylactically decrease their episodes. Side effects are not major. Most patients do pretty well with these guys. If they are going to have side effects that would potentially warrant discontinuing the drug, those might be fatigue, lethargy, depression. You're going to see those same sort of side effects if you're using beta blockers for hypertension, if you're using beta blockers for another use, like heart failure or dysrhythmias. One thing about beta blockers that I don't think I've said so far is that we don't want to have someone stop them suddenly, because basically what happens is they're blocking the catecholamine stimulation of the heart, and so the heart becomes super sensitive to catecholamines with long-term use. And if you suddenly discontinue the medications, you can see this like rebound excitation, which can be super stimulating, causing at the bare minimum angina, maybe tachycardia, and potentially maybe even a heart attack. So people on beta blockers need to be cautioned to not just go cold turkey on those. If they're going to come off of them, they're going to need to have some support and titrate down over time. Okay, excuse me. The calcium channel blockers, these guys, like I said, they're specifically known to relax arterial smooth muscle, which of course reduces blood pressure. So they're going to be used for blood pressure as antihypertensives as well. They slow conduction, which will decrease heart rate, which will decrease work. So that's a plus for angina. And specifically, you can see in that third bullet, they dilate coronary arteries, bringing more oxygen to the myocardium, and they're really good at that. So a moment ago, I said that if you have plaquing or atherosclerosis, narrow vessels, hardened narrow vessels, then vasodilating your coronaries isn't oftentimes an option. However, if you have that type of unstable angina or the variant angina, the one that is as a result of this vasospasm, those patients are going to respond really well to the calcium channel blockers. So for those people, this probably is the drug. And again, the side effects of these guys, both beta blockers and calcium channel blockers, are pretty well tolerated. Generally, if they do have symptoms, they're related to vasodilation, and you can see on there, they're pretty minor for the most part: dizziness, headache, swelling of ankles and feet, maybe hypotension, which kind of makes sense with vasodilation. You might see a slowing of the heart rate, and maybe heart failure. Calcium channel blockers, calcium is a big player in myocardial contraction, and so I think there's a reason to be worried potentially over the long haul with calcium channel blockers potentially precipitating heart failure in people that are susceptible to heart failure. However, for the general population, I think that it will be minimal and not something we need to worry too much about. All right. So this drug we haven't talked about doesn't fall under, it's not a beta blocker, it's not a calcium channel blocker, nor is it a nitrate. It's kind of a strange drug. It's called a phosphodiesterase inhibitor. And basically what it does is it causes selective vasodilation of the coronary arteries. So our calcium channel blockers, that's why I'm talking about it now, dilate the coronaries. This drug, dipyrimidine, does it as well. Persantine is the brand name. But this is not going to be useful for an acute attack either. Um, one of the one of the roles for this particular medication may be in decreasing the requirements for nitrates, which we're going to talk about next, which are kind of the drug of choice for an acute attack. And another thing about nitrates is they tend to exhibit tolerance, which means they kind of lose effectiveness over time, or you might have to continue to increase the dose, which can be dangerous to maintain the effect. So these drugs may have a role there. They're not really used, they were not approved as anti-anginal medications, and they're not used often as anti-anginal medications, kind of in specific cases. They're used more oftentimes as an anticoagulant agent because they decrease the stickiness of platelets. But there is potentially a use here in terms of angina. I'm not going to test you on that, but I wanted to put it out there, and it's in your book, so I actually needed to put it in there. Okay, so the last group here are the nitrates. These guys, there's two that I want to talk about. The first one being nitroglycerin. This is the prototype nitrate. So what these drugs do is they essentially, once administered, they travel to the tissue and they get converted to nitric oxide in vascular smooth muscle. And nitric oxide is a big cell signaler. It's a big player in vasodilation, a very potent vasodilator. It's something we produce on our own. Nitric oxide is our kind of endogenous vasodilator, and it relaxes both arterial and venous smooth muscle. It's really an interesting cell signaling molecule. So where these drugs really seem to, have a role is that they are really good at dilating veins, which of course is going to decrease preload, right? Because we're going to decrease the amount of blood returning to the heart, which then means the heart has to pump less, which means it has to work less hard, right? So when it's working less, when the work is decreased, that means that lowers oxygen demand, which is the big problem here, right? We're not getting enough oxygen if someone's having an angina symptom. And like I said earlier, the nitrates do also vasodilate a little bit of the coronaries, and originally that seemed to be like what their mechanism was and why they were effective, but it turns out that that's not so much. That's not their primary mechanism of action, and the benefit of the drugs comes more for the venous dilation than it does from the coronary artery dilation. But they do that, and because of their ability to relax both arterial and venous smooth muscle, they may be useful for that variant angina. I don't know if you would. They're useful in what I should say is they're useful in an acute situation also. So maybe if someone has variant angina and they're having an acute attack, this will still be okay. If they're not having an acute attack and you're trying to diminish their frequency of attacks, potentially a calcium channel blocker. You can see the adverse effects. Flushing, mostly have everything about vasodilation. Flushing of the face, a throbbing transient headache, meaning it comes and it goes, which is sort of interesting. Orthostatic hypotension, which means when they go from a sitting to a standing, or a lying to a sitting, or a lying to a standing, they get kind of dizzy. That's all because of the vasodilatory effect, and they can get kind of faint, also syncope, when they stand up. One thing I do want to mention is that there are some drug interactions. The big one is with sildenafil, which is Viagra, or any other phosphodiesterase 5 inhibitors, which is what Viagra is. And it's a vasodilator, of course, as I'm sure we all know. And the reason why these drugs do not want to be combined is because it can profoundly decrease blood pressure, causing major life-threatening hypotension and potentially circulatory collapse. So no nitrates with the Viagra. Not gonna work. Not a good idea. One other drug in the nitrate category, one thing I wanted to say, I want to go back here for a minute. So one thing I want to say is with the nitrates, they exhibit something called tolerance, which means that their dose becomes less effective over time, and you might have to increase the dose. And this is going to be also a situation with the drug on the next slide, but not as significant with that particular drug. And the other thing I want to mention about nitroglycerin is that it can be administered in all kinds of different forms. And if you look in your book, it talks about, sublingual and oral and just patch, IV. There's all kinds of options. And they're all a little bit different in terms of their speed at which they are effective, I guess is the main thing, and their duration of action. So I just wanted to mention that because that's written in your book. You don't need to know about every single possible way you can administer a nitrate for this class, but you will see them being used, and you'll see them in all these different forms depending on the condition and the patient and the circumstance. All right, second to last is isosorbide dinitrate, which is also a nitrate. This is not for acute, whereas the nitroglycerin is an acute medication. So this particular type of medication is used prophylactically. It's got a longer duration of action, which is why it's used prophylactically. It does tend to lose its effectiveness over time, and one way to sort of mitigate that effect is to not take it continuously. So oftentimes what they'll recommend is to prevent, a period of time, a drug-free period, which would be at least 14 hours, if not more. And that helps to prevent this tolerance. The term tolerance, we'll talk about tolerance more in our central nervous system unit, but tolerance essentially means that any drug that exhibits tolerance means that you have to continually increase the dose to maintain the effect, if that's possible. And in most cases, when you increase the dose, you increase the potential for side effects and toxic effects. So that isn't always an option. So in this case, the ability to kind of modulate that is one of the ways you can modulate it as these drug-free periods. And because this is used prophylactically and not as an acute medication, that's a little bit more of an option. And there's a couple different, there's isosorbide mononitrate as well, which I'm not going to talk about, but there's some subtle differences there, both of which is, with both cases, we're using this more prophylactically. The side effects are pretty minimal, maybe tachycardia, but it's not a big deal. Headache, postural hypotension, especially if postural hypotension, again, is the same as orthostatic. When they go from sitting to standing or lying to sitting or lying to standing, they get dizzy. This is going to always be worse with alcohol, but alcohol is also a vasodilator. So that's something to always note with nitroglycerin or with isosorbide dinitrate, is that we need to be a little bit cautious with our other vasodilators, including Viagra. And then there's some GI effects you can see, which are pretty common with lots of medications. These contraindications and or cautions can be also applied to our conversation about nitroglycerin. Storage of the medicine is important. It's kind of sensitive. It doesn't like to be in bright light, so it kind of needs to be in a cool place. It doesn't like to be in high temperatures, so you don't want to carry it around in your pocket, for example, or put it in your glove box. It doesn't particularly like moisture, so people need to be cautioned in terms of how to store their medications in order for it to maintain its efficacy. Nitroglycerin as well as isosorbide dinitrate is going to be contraindicated in patients with glaucoma because it can increase the pressure in the eye, and same kind of contraindication with any kind of head trauma, cerebral vascular hemorrhage or history of one, or any condition where we might see an increased intracranial pressure, because these drugs are going to increase the pressure even more. They're vasodilators, so they're going to bring more blood to all over the place, and that would be potentially catastrophic in those cases. So that is our second nitrate. So the drug nitrates, specifically nitroglycerin, is going to be our drug of choice for acute use. And then in terms of prophylactic use, it kind of depends on the situation. We have a lot of options: beta blockers, calcium channel blockers. This guy, isosorbide dinitrate, is used frequently. Okay, the last one I want to talk to you about is this new-ish drug outside of the other totally different animal. And it's called Ranexa is the brand name, or ranalazine is the generic name. This was approved in 2006. And it's a totally different kind of a drug. It's a partial fatty acid oxidation inhibitor. What? Which basically means that we don't really know exactly how it works, but what it seems to do is it seems to shift metabolism of cardiac muscle cells towards glucose instead of fatty acids. Fatty acids is a preferred fuel source, especially for long-term energy, which we know we need a lot of energy to sustain the heart, right? 60 to 100 beats per minute all the time, pumping your entire blood volume every 1 minute. So this particular class of medication seem to be able to shift towards glucose metabolism as the primary energy source, which decreases the metabolic rate and oxygen demand of the myocardial cells. It seems. It's a little bit of a question mark there, but that seems to be what's going on. This is not standard of care and probably are not used that often, but they are a potential drug for chronic angina that is unresponsive to other treatment. So it's sort of an interesting drug. It doesn't affect hemodynamics at all, right? It's all about metabolism of these cardiac muscle cells and using glucose as our fuel source. So again, angina is a symptom, right? None of these medications are fixing the problem if somebody has angina. The reason why we worry about angina, and I like to think of angina as kind of a warning sign, a red flag, that this person is at risk for a sudden cardiac event, namely a myocardial infarction. So when the cardiac muscle, the myocardium, is deprived of oxygen, becomes ischemic for a period of time, and not all that long, if the perfusion is not restored, then what happens is that tissue dies. And that's what a myocardial infarction is. That's what a heart attack is, right? It's an area of ischemic tissue that's past the point of no return, and then those cells become necrotic and they die. And that, of course, is a whole other thing. So what we're trying to avoid is that, of course. So one of the benefits, if you want to think of it like that, of angina is telling you, hey, we got a problem here. There is something going on, whether the vessels are spasming, right? Whether there's a nitric oxide production issue, which is a possibility, or whether there's coronary atherosclerosis, where we've got narrowing, or potentially a clot, or whatever. Something is keeping blood from getting to the heart, which is where we need it to be. And the symptom of angina needs to be taken seriously, in my opinion. And, I'm not saying that you don't want to treat it, but that just keep in mind that that's not the end game, right? There's more to what's going on, and so it needs to be kind of managed in that respect. So that's our conversation about angina. Hopefully that was helpful, and I will see you back with the antihypertensives. And there's a lot of them, so we'll have a lot to do there. All right, see you later.